supine, grab the tibia and fibula, add the hip into flexion, external rotation, take up tissue slack by leaning back, and apply a high velocity, low amplitude thrust. This also can be done through the femur if the patient has a painful knee. Again, flexion, external rotation of the hip, take up tissue slack by leaning back, and apply a high velocity, low amplitude thrust to the hip joint. This helps improve. With the patient supine and the hip flexed, a towel is placed along the thigh to add padding for a mobilization belt. The belt is placed as close as you can to the hip joint and across the therapist's hips. The hip is passively taken into hip flexion, and a glide is applied in a caudal or lateral caudal direction and maintained while hip flexion is assessed. If still painful, the glide can be adjusted into a different angle, and again, hip flexion is reassessed. When pain-free, maintain that glide and repeat multiple times to improve hip flexion mobility. Hip flexion is important for with the patient supine, have them cross their leg over the uninvolved side with their foot flat on the table. The therapist will place their hands over the knee and then use their sternum to add overpressor, pressing the femur downward towards the hip. Mobilizations are performed at varying levels of oscillations and amplitudes. Multiple repetitions and sets are required to improve hip capsule mobility. With the patient prone, passively extend the hip to end range, feeling for stiffness, while at the same time applying a posterior to anterior force, looking for end range and end feel. Making sure that the lumbar spine does not go into too much lumbar extension. This can be used in the assessment as well as the treatment, applying oscillations in the posterior to anterior force. A belt can be used to help stabilize the leg into extension as well. Multiple repetitions are required to improve hip extension, which can benefit terminal stantive gait. In the Thomas test position, you can stretch the iliopsoas using a post-facilitation stretch technique. Ask the patient to contract your iliopsoas by lifting their knee towards the ceiling against your hand as hard as they can for 5 seconds and then letting go. It's a good idea to practice once to make sure the patient is able to let go and let their legs fall so you don't push against their resistance. Okay? So again, go ahead and lift your knee to the ceiling. 1, 2, 3, 4, 5, let go, and stretch. Stretch for 30 seconds. With the patient prone, flex the involved knee to 90 degrees. Maximally internally rotate the hip on the right while feeling the PSIS on the opposite side move into your hand. Once you get to end range, stabilize the hip on the right side while applying a posterior to anterior mobilization to the opposite PSIS. The patient should feel a stretch on the right hip. Make sure you keep your elbow locked out and your sternum over the PSIS. If you note that the patient has excessive laxity in their knee, the femur can be held at the distal portion to hold the internal rotation without overstressing the knee joint. Again, the mobilization is performed through the opposite PSIS.